Hereby I open this academic ceremony in which Henry Davies will defend the academic thesis, End of Life and Palliative Care for Vascular Patients. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. So, Pro-Rector, Chair, members of the Reading Committee, supervisors, and members of the audience, thank you for the opportunity and taking the time to listen to my PhD defense on end-of-life and palliative care for vascular patients. So I'll start off by introducing the two vascular conditions which we've looked at for this thesis. Then I'll go on to talk about end-of-life care and the 5 papers we've done on this area. Then I'll finish by summarizing and defending my propositions. So, hardening of the arteries. If it happens in the legs, it can cause chronic limb-threatening ischemia. This is when the arteries get too narrow or block and not enough blood gets down to the feet. So it can cause this, this, and this. Obviously, it's a risk to the leg, but can also lead to death as well. But we're surgeons, so we can fix this. What we do is we join a pipe from above the blockage to below the blockage, taking blood down to the foot in the hope of saving the leg. If the hardening of the arteries happens in the aorta, the biggest artery in the body, it can cause it to expand and burst. From the outside, it looks like this. This is what it looks like from the inside. But we're surgeons, so we can fix this as well. We remove the aneurysm and we join a pipe from above where it started to below where it finished. So that's the head of the patient up here, and that's the legs down there. So, what I'll be asking this afternoon is, should we be fixing all of these? Or should sometimes we stop and not fix them? Or should sometimes we fix them, but also be doing other things for the patient as well? So, where did this all start? When I first got my job in vascular surgery training, I was on the receiving end of a lot of unkind comments, such as, well, all of your patients just die anyway, or remember just to chop a bit of the leg off at a time. And I thought, well, let's have a look at this and see if there's any truth in the matter. So if you compare with cancer patients, patients who traditionally get very good palliative care, you see that our patients, if you've got a leg ulcer, they do a lot worse than the majority of the cancers. So all those cancers above the red line, we do worse than those in terms of survival. If you compare with aortic aneurysms, you'll see it lands in exactly the same place. After 5 years, more of our patients are dead than all of those cancers above the red line. And this is for aneurysms that we've fixed. So I know what you might be thinking, you're not fixing them very well, but it's actually because they have a lot of other comorbidities, are very unfit to start with, and they actually die from other causes. And this is something that we'll see again later in the talk this afternoon. So, end-of-life care, what is it? Well, it's actually not what a lot of people think it is. There's a common misconception amongst the general public and also health professionals that end-of-life care is going to turn off the treatment, turn off the machines, and just wait for the patient to die. It's not this. End-of-life care is palliative care, which can be given alongside disease-modifying care. So it's not either or, you can do both. Palliative care is the treatment of the physical symptoms, so the pain, the psychological symptoms that come along with these conditions, like depression or anxiety, and addressing the social and spiritual needs of not just the patient, but also the carer and the family who have been often heavily involved with the discussions and the decisions throughout the illness, and they're the ones who are left to pick up the pieces after the patient has died. So, UK NICE 2019 end-of-life care guidelines say that anyone with advanced, progressive, incurable conditions, people with frailty, lots of other conditions, or who are at risk of death from a sudden deterioration of their condition, they should be offered end-of-life care. For the guidelines from the Netherlands, they arrive at the same conclusion via a different route. They ask the doctor to ask themselves, would you be surprised if this patient was to die within the next 12 months? If the answer is no, they should be offered end-of-life care. They also talk about people with life-threatening conditions or frailty, should offer it to them, and also anyone who's at risk of dying from an acute deterioration of their condition. Both of these guidelines say it's not really care in the last few days of life, it should be in the last weeks, months, and even years of life that it's offered to have a meaningful effect. So, We've introduced chronic limb-threatening ischemia, we've introduced aortic aneurysms, and we've talked a bit about end-of-life care. So the research question that we're asking this afternoon, and that I've been asking for the last couple of years, or we've all been asking, is end-of-life care for CLTI and aortic aneurysms sufficient and effective? What's the research around this? What's the training provision? And if it's not effective, what do we need to be doing to make it so? So now I'm going to talk about the 5 research papers that we've done for this thesis. So where does all good research start? It starts with a review of the evidence. So that's what we did. We started looking at all the published evidence on palliative interventions for people with chronic limb-threatening ischemia or aortic aneurysms, and the news wasn't great. We found that there was only 8 papers. It's mostly low to moderate quality evidence, only looked at patients in hospital mainly, and most of the studies didn't ask the patient for the outcome. They just looked at cost, hospital utilization, things like that. The good news was they did find, for the outcomes they looked at, they did find positive correlations with them. So, but yeah, so this paper generated a contact between Maastricht and Leeds University because they'd been asking the same question and looking at that as well. And it was the beginning of a beautiful collaboration which led to all of the subsequent work in this paper and this thesis. So then we looked at aortic aneurysm. We decided to do 3 papers looking at our own patients, and all of them looked at survival, cause of death, and then the provision and outcome of end-of-life care. The first one was looking at 220 patients in the UK and in the Netherlands who had aortic aneurysms big enough that we should fix them, but either from them being too high risk or the patient declining surgery, we decided to not do an operation and just manage them conservatively. So the interesting thing about this paper is 2 big vascular centers in different countries working from the same guidelines have almost exactly the same survival, as you can see by the blue and red lines there, all the way down to 36 months, by which point over half of the patients had died. The other interesting thing is only 19 of the 105 people who died actually died from a rupture. All the others, even if we'd fixed them, would have died of other causes. So what's the end-of-life care story? It's that not very good. Not many received it. If they did receive end-of-life care, it was only 3 days before death. Older patients were more likely to receive it, but the palliative care input did improve some of the quality markers that we looked at. It didn't improve all of them, but we think that that's probably because it happened so soon before death that it didn't have time to make a meaningful impact on their quality of life. Next, we looked at patients who had emergency admissions to vascular hospitals. So this was representative of an acute deterioration in their vascular condition, making them appropriate to have end-of-life care according to the Netherlands and the UK guidelines. We found a very similar story. A third of the patients were dead within 2 years, and if you looked at the ones who had CLTI, ulcers, and aortic aneurysms, 40% of these were dead within 2 years. So very poor survival rates. And end-of-life care story is almost identical to the previous paper, so hardly any received end-of-life care. If they did, it was 10 days before death. Older patients and those with kidney and heart disease were more likely to get end-of-life care, and palliative care improved a couple of the quality markers, but not all of them, probably for the same reasons. Then the third of these 3 papers, looking at our own patients, looked at chronic limb-threatening ischemia. Again, a third of the patients dead within a year. Those who had undergone amputation for CLTI, 50% of those were dead within 2 years, which is much worse than most of the cancers on the page I showed you at the beginning. So end-of-life care, though, was the same. Not much end-of-life care. If it did happen, it was just 5 days before death. Patients with kidney or heart disease were more likely to receive it, and palliative care improved some, but not all of the quality markers. As a result of the papers we'd written, we thought it was appropriate to, again, review the evidence and look at the international guidelines, training curriculum, in the hope of developing a structured care objective consultation which could facilitate these difficult and important discussions towards the end of life. So what did we find? We found that there's a lack of high-level evidence, multiple guidelines, surgical and non-surgical, but actually in practice they weren't being adhered to. minimal mention of palliative care, no mention of end-of-life care in UK or European vascular training curriculum. So this was a structured care objective consultation. It looks at situation, objective, analysis, and plan. So situation, you say to the patient, you've not just got a problem with your leg or your aorta. This shows that you're probably at a higher chance of dying than someone who was the same age but didn't have this condition. Then you find out from them, what do you want from this medical encounter? You know, would they be willing to have a long ICU stay, multiple operations with long recoveries to get back to what was probably not their baseline before coming to see you, and find out, you know, those kind of things. Then you analyze each of the options available to them with giving them realistic outcomes of each option. So for example, if I amputate your leg, you're almost definitely not going to be able to get back home. You're more likely to go to a care home, and so things, you know, that they're clear about that at the beginning. Then you, with the patient and the family, and you come up with a plan for the subsequent management. We think that if this was used, it would increase the likelihood that the management plan aligns with the care objectives of the patient. We also know that, I'm pretty sure that if it was used for the previous 3 papers, it would have increased the outcomes of all of those. So, in summary, this thesis has highlighted that we've got good evidence about the life expectancy of chronic limb-threatening ischemia and aortic aneurysm patients, but the provision and delivery of end-of-life care is poor. It's highlighted a lack of evidence around barriers towards receiving end-of-life care, effective palliative care interventions, evidence for new palliative interventions, and also how to train vascular surgeons. So, going forward, we need to establish high-level research with patient-reported outcomes in the areas mentioned above. It's clear we need to have a conversation with the major funding bodies because research of this kind is very expensive. We need, with regard to research and clinical, we need strong links, not just between the vascular surgeons and the palliative care professionals, but also between the primary and secondary care setting to ensure continuity of care between the 2 places. Next, we need to look at new palliative interventions, in particular for things like pain in CLTI, for which there's no evidence on currently, and it's not right that people should be dying in pain because of a complete lack of evidence. Next, we need to look at establishing formal training for vascular surgeons, and finally, we've been lucky enough to present this at conferences all around the world, but when we do, we find that we're pretty much the only people talking about it, so there needs to be a bigger platform for this to talk about end-of-life care in vascular surgery at the major vascular conferences. Okay, so last of all, none of this would have been possible without the excellent collaboration between Leeds and Maastricht University. And for this, I'm eternally grateful, and I'm also eternally grateful to all these people. And to celebrate the end of the presentation, there's a picture of Leeds, which I hope you can all come to one day. Thank you very much. I give the word back to the Prorector.
Thank you for your presentation. The opposition will be opened by Professor Muris, Professor General Practice at this university. Professor Muris is also the secretary of this degree committee.
Thank you, Mr. Prorector. Dear candidate, as a GP, I applaud your thoughtful attention for palliative care from a vascular surgeon perspective, which is more than we are surgeons and we can fix this, as I learned. In my work, it is important to eyeball and weigh multidimensional palliative care needs in patients. So I scanned through your book, and my question is a twofold question. So what are these multi-dimensional needs of your populations? And what do PC teams, not primary care teams, but palliative care teams, need concerning education in this population?
Okay, highly esteemed opponent, thank you for your compliments and thank you for your excellent question. So we haven't done the research completely, but from everything that I've learned, and also from my experience of treating the patients, it depends whether, if you look at these two groups of patients, it depends whether they're aortic aneurysm patients or chronic limb-threatening ischemia patients, because they have very different needs, and we think they have needs unique to to people without vascular disease. So if you look at the first group, people with chronic limb-threatening ischemia, the main thing is pain, because a lot of them are in pain all of the time. There's a 2017 systematic review looking at analgesia for ischemic pain, and it was unable to recommend anything from the evidence available. So one of the ways to treat is with an amputation. It's often a palliative amputation in order to get rid of the pain, but that's one of often there are patients who, you have these care objective conversations, an amputation is not right for them, but then they're left on the ward in a lot of pain despite the WHO pain getting to the top of that. So one thing is...
So I read about multidimensional needs, but now you're saying the most prevalent reason to refer to PC team or to do an amputation is pain. So it's, you don't have to take all the data from your book, also from your clinical experience, but we as GPs think there are spiritual needs, social needs, physical needs. So is in your area only pain a palliative care need?
So pain is a big one for chronic limb-threatening ischemia, but definitely, yeah, social needs in terms of where does the patient want to be cared for, what are their care priorities, and where would they like to die. And then putting the logistics and processes in place so that if they do want to die at home, that we can make that possible, because that's something which very rarely happens. 50% of people, most people want to die at home if you ask them, but 50% end up dying in hospital. So putting that, so that's the social side of things, the education for them, for their carers, to enable them to not come into hospital and have a home death, with the pain management. And then, yeah, other social side of things, part of it's making them aware that they are more likely to die within the next, couple of years if they need an amputation for CLTI, so that they can get their affairs in order as well. That's a large part of the social side of things. But then with aortic aneurysms, it's a lot of the similar ones, so the social side of things, the spiritual side of things, and but then the psychological and the physical are different, because with aortic aneurysms, you don't really have the pain. So it's largely asymptomatic in most patients. So there's not much on the physiological side, but then for the psychological side, quite a lot of living with something which is potentially a ticking time bomb. And the depression and the anxiety and the worry that comes with that. So, but we need to, part of it is do more research to find out, does telling the patient this improve their quality of life? Is it something that they would rather know? And B, if it is, what's the best way to explain it and to treat the anxiety and the depression and things that come with it?
And all these factors, anxiety, social problems, dying, the wish to die at home. I recognize that because euthanasia in my country, most of the surgeons, they call me to do the euthanasia. So I think also from the hospital there is an urge that people go home, and it aligns with the wish of patients themselves. I agree. So all these things together, that was my second question. What does that mean for the skills, the attitudes, the knowledge of those palliative care teams? What should they have, and should it be improved, or what's your opinion about that?
Yeah, so we've worked with quite a few palliative care consultants, and I've had discussions with them about what do they offer our patients, which is unique to vascular patients, and actually there's very limited awareness of our condition, of the conditions which our patients have. They don't have specific analgesic methods or for example, sometimes one of the things people have is that the gangrenous foot has a very strong odour. So there are some interventions for that where you could put shellac, which is a treatment to cover the leg and stop that odour. But the palliative care professionals in the UK, which I've spoken to, they don't have a system for that, or they don't have any special interventions for our patients. So that's one thing that we really need to do by increasing the cooperation between vascular surgeons and palliative care doctors in order for us to teach them and for them to teach us.
So there's room for improvement.
Definitely.
Thank you very much. I'm very satisfied with your answers, and I will give back the word, if that is English, to the pro-rector.
Thank you.
Thank you. The opposition will be continued by Professor Hincliffe, Professor Vascular Surgery at the University of Bristol in the United Kingdom. Professor Hincliffe was member of the assessment committee, and we highly appreciate your participation to this academic ceremony.
Thank you, Pro-Rector. Henry, so we've heard a lot about the interventions, but can you tell me what you think are the active ingredients? So that builds on what we've already heard before. So what are the active ingredients, and how do you evaluate whether something is good care or bad care in this group of patients?
Thank you for your question, highly esteemed opponent. I think it's similar to the work you've done recently looking at CGA, cognitive geriatric assessment, in terms of it's often a difficult thing to assess the outcome. For these studies, we looked at the things which are available for a retrospective study. So we looked at whether they'd had family documented input in advanced care planning decisions, so things like preferred care priorities, preferred place of death. And then we also looked at the other markers which are available, so time spent in hospital in the last 6 months of life, time spent in the ICU in the last 30 days of life, unplanned admissions, and referral to palliative, to community palliative care services. That's one way to assess it in a retrospective study, but it's not the ideal way to assess it. It would be better to have patient-reported outcomes and qualitative studies, which could better assess. In terms of how to assess it, clinically, you could use the markers that we used retrospectively, but I think essentially it's best to be asking the patient for things like health status, quality of life, SF36, in order to get and also asking the family for their opinion on care and communication after the patient's died as well. That's the best way to assess it, but also the most expensive.
And you alluded before that pain was a big issue. Patients with diabetes and CLTI often don't have pain, and CLTI is often quite a sort of heterogeneous disease, actually. In any single patient, how do you, what's the principal issues at play that might be beyond pain? What other issues might you be considering, trying to evaluate, trying to treat?
Yeah, so I think that's what part of the care objective consultation helps to assess what thing that the patient needs help with. And if it's a patient with diabetes who doesn't get much pain, then it might be that they need the other aspects of palliative care. So one thing is if they have serial amputations, that their functional ability, so ability to walk, but also to do daily living abilities, it all reduces. So part of it would be the social side of things to make sure that they have the help there that they need and support in that area for them and also their family. And also there's like the psychological effect of it as well, because someone who's young with diabetes and CLTI, particularly if they have kidney disease as well, they have extremely high mortality rates, even though they're only 40. So I think an area that they don't get, that they definitely don't get the equivalent as someone who has palliative care for cancer, is in the psychological side of things, so dealing with the depression, anxiety, and coming to terms with the fact that they've got a 1 in 2 chance of dying within the next year, sometimes, or 2 years.
So I'm not sure about the Netherlands, but in the NHS in England, we're very cash-strapped with very severe restriction on services. Can you tell me who you think should be responsible for the delivery of this intervention, so end-of-life care, palliative care? Because what you showed, I think, very clearly was that the overwhelming majority of patients with the aortic aneurysms that you evaluated never died of their ruptured aneurysm. So should it really be the responsibility of the vascular surgeon to deliver this intervention?
I think financially, the situation in England at the moment is a big big palliative care foundations are normally funded 2/3 by charitable donations and fundraising and 1/3 by the government. Financially, I think it should be all financed by the government. I think it's an area which is overlooked, and a lot of people get a very poor quality of death just purely because it's not funded by the government. So I personally think it should definitely be funded by the government. And the second half of the question is that, if there was closer integration between the vascular surgeons and the palliative professionals, then there would be greater understanding, and also between the primary and secondary care settings, there'd be greater understanding of the needs of our patient from the palliative professionals, but also it's this, when they go into the community, none of them being on the gold standards framework, so none of them end up getting the palliative care. But if we'd met them in clinic when they were eligible for end-of-life care and registered them on the gold standards framework, and there was better communication and understanding between us and the GP practices, I think that then that would actually, they're into that system, and it wouldn't then be a responsibility of the vascular surgeons because we're all working so closely together. So in an ideal world, it would be better funded and better cooperation.
I'm just going to bring you finally back to outcomes. So in Chapter 5, those patients receiving a palliative care consultation spent, I think, more time in hospital, had a greater number of readmissions, and spent more time in ICU. Was that a surprise? And why do you think that was the case? Because it certainly surprised me, and I think you actually commented in your discussion about it. That seems quite paradoxical. Can you explain how that was of benefit to patients?
Yeah, I was initially surprised, but then when I thought about it, I wasn't surprised because we have the respect forms and the DNA CPR forms, which they're often not filled out. And it's just it comes down to the fact that the average time of that palliative intervention, of discussing the care priorities and where would they like to die, was happening so close towards the end of death, like 3 days or 5 days or 10 days, that actually it was the fact that they're already in ICU or they're already really unwell in hospital and have been in hospital for ages, which triggered the palliative care referral. So yeah, I could see, and that comes down to lack of understanding of what end-of-life care is. Even in hospital, when you say someone's end-of-life, they always think you're talking about terminal care. And even sometimes you'll speak to palliative care and they say, we're not coming to see the patient, he's not actively dying. So it's that, what we want is for them to, when they're in clinic and eligible for end-of-life care, to have those discussions then. For example, with the aortic aneurysms, at the turn-down clinic, we plan to then bring them back a month later when they've had time to digest it, read about it, speak to friends and family, and then enter these discussions so that they can make decisions about where they would like to die, not when they're admitted to hospital with a sepsis, dehydration.
Okay, great, thank you.
Thank you.
Thank you. The opposition will be continued by Professor Van Zuilen, Professor Palliative Care at Amsterdam University Medical Center. Professor Van Zuilen was member of the assessment committee, and we also appreciated that you are participating to this academic ceremony.
Thank you. Dear candidate, First of all, I want to congratulate you with this thesis, and of course, I also want to congratulate your supervisors on this achievement.
Thank you.
And I also want to use this opportunity to say a big thank you to you, because your work was of a great value for us for a project we are doing in Amsterdam UMC on early advanced care planning, also on the vascular surgeon ward. And I will discuss that later on.
Excellent.
But first of all, I want to ask if one of your paronyms, and I think Celia is your mother, if she is able to quote proposition number 12 for us.
I think it's this paranym.
But of course, it's okay.
Number 12. To cure something, to treat often, to comfort always.
Thank you. When you have these words in mind, and then I read your introduction, and you were exploring on the history of palliative care. It started officially with Cicely Saunders in the 1960s, but I think I agree with you that you explored it a little bit earlier on, around 1880, I remember by head. But what I wonder, with this quote in my mind, why do we talk about starting of palliative care? Why do we not talk about starting the history of curative care?
Thank you, esteemed opponent, for your kind compliments and for your question as well. I think we could start with talking about the history of curative care, but I think that's the thing that we always do. And in medicine, we always you see a patient, you think, well, how can I fix this bit? Or what can I give them to make them better and keep them alive? But sometimes there's nothing that you can do to fix the whole patient with one thing or with one treatment. So, yeah, I think we could start with a history of how to cure patients, and it would be a long history, probably similar length to the palliative care history. But for this thesis and for this work, because I'm so interested, because it's all about, we've already gone down the road of we're trying to cure everything, fix every leg, fix every aorta, but should we be asking these other questions as well?
Yes, I agree totally with you. Of course, we doctors, we want to cure patients, but we have to agree and we have to see that it's not always possible. And I think that's a great message of your work and also the great importance of your work. As I said, we are doing a project on early advanced care planning in Amsterdam UMC. And we use the surprise question, you already mentioned that one, as a red flag. In every patient with an acute admission, we ask the nurse to ask by herself or himself this surprise question. And when the nurse answered this question, I wouldn't be surprised when this patient died within a year. Then the nurse goes to the surgeon, in the case of the vascular surgeon ward, and the nurse is going into a talk with the patient. It is, for us, a try to get to the early palliative care and not to only terminal care, and not to be there the last 3 days of a patient's life. When you relate this project with the nurse in the center, do you think it will work when you relate it to your research?
Yes, I think that's a really interesting way of doing it. And from the loss of the research that's coming out at the moment, the best predictor of patient outcome is not any of the fancy scoring systems we've got, but it's just the surgeon's gut feeling when they're looking at the patient at the bed and they're thinking, how much are they sweating more than they were sweating previously, or how much has their heart rate gone up in terms of, can they see that, do they just have a feeling in their gut that this is going to get worse? And I haven't seen any papers to say whether it'd be more sensitive or specific from nurses rather than if it's a surgeon doing it. Nurses obviously have a lot of experience and they see the patients a lot more for more time while they're in hospital than the consultants. But I would guess that maybe the surgeon would have a better gut feeling because they have more consequence if everything goes wrong and they end up in court more often than.
But why don't the surgeons do it? Because that's my point. I can't reach the physician, not only surgeons.
Yeah, so that's the other thing though. Maybe nurses are better because they wouldn't have the bias that surgeons have, which is to the man with a hammer, everything's a nail. And you see things that you can fix, you recognize them, and part of our job is to take people to theatre and do operations and put stents in. So, and there's not, for surgery, there's not actually really strong evidence either way, and in vascular as well, when you compare it with like cardiology, for example. So when there's not, when there still is equipoise, and it's part of your job and your training to fix things, then maybe the nurse would be better to ask that question initially. That's really interesting,
Keep that in mind, please. Yeah. And I think we will explore it later on in this commission. I think my time is over.
Yeah, we could do a paper.
Thank you very much for your answer.
Thank you.
The opposition will be continued by Professor van der Laan, Professor Appropriate Care at the TIA School for Business and Society at the Tilburg University here in the Netherlands. Professor van der Laan was member of the assessment committee, and also for you, thank you for joining this ceremony.
First of all, my compliments to you, Mr. PhD candidate, and your research team. Special to Supervisor Professor Mees and Professor Scott with his beautiful and impressive dissertation. It concerns an important subject in increasing aging vascular population. I completely agree with you that we need to pay more attention to palliative care and vascular surgery. And I am asking the following questions precisely to implementation this further in my practice with your answers and experience. So I will steal your answers. I read your introduction, which is very shortly, very intensively, and that's my first question. On page 8, you describe the definitions of end of care life, terminal care, and surgical palliative care. What I miss in this introduction is the term conservative treatment. Did you do that with a special reason? And is there a difference in your experience between conservative treatment and surgical palliative care, to start with?
Highly esteemed opponent, thank you for your compliments and thank you for your question. I think, so I defined those ones. And I think with palliative, because palliative care, end-of-life care being palliative care which can be given alongside disease-modifying care, I think that, if you decide that someone's conservative, so non-operative management, for example, then you are giving them palliative care by default. And with palliative care, it's something that it's better to offer and them not need it and decline, rather than to not offer patients who do need it. So I would say the evidence isn't out there completely, but my feeling is that anyone who you're deciding conservative, managing without an operation, you could have that structured care objective consultation, and if you get through it and think, actually, this person doesn't have any problem with the physical side of things, they don't have any problem with the psychological, they don't have any social or spiritual needs which aren't being addressed, then you continue with the conservative care. But then by definition, they've had end-of-life care because they've been offered it and declined it. So that's why I
completely understand you, but I a little bit disagree with you. In my opinion, we have 3 options in surgery, namely surgical treatment, endovascular treatment, and conservative treatment. And when this not happens at all, or have bad luck, then you go to the palliative surgery. Because when we go to your chapter on chapter 2, page 23, you're describing a study of Steunenberg, in which you say this has conservative treatment, and in this group, 60% of the patients are still alive after 1 year. And that's, I'm struggling, when do I start in this group of patients palliative care? Do you understand me? Because they are still living a life and have a good quality of life. With conservative treatment and not with palliative care.
But I think, though, if they fulfill one or more of the criteria by a wide variety of guidelines that are around, so either the UK 2019 guidelines or the Netherlands 2017 guidelines, if they fulfill those to be offered end-of-life care, then I think they probably should be having it in addition to palliative care. And you can offer it and them say, I don't want it, and then you could just say, okay, well, I'm continue just to treat them conservative without they're not under palliative care because they've declined it completely. I guess they would be considered conservative care. But all those patients would fulfill, pretty much all of those patients, or in all of the patients in any of the papers in this thesis fulfill at least 2 of the criteria, if not 3.
Okay, I will take it home. I will give them also palliative care. Do you know, I'm struggling with that, because how do you measure quality of life in the last phase of their life, of these patients? And do you have you ideas about measuring quality of life for the caregivers in these last few months of their life?
Short answer, please.
What's that?
Short answer.
Okay, so in the thesis, we did it just with the methods that were available to retrospective studies, so the ones I mentioned earlier about time in hospital, time in ICU. But that's not the ideal way to do it. The ideal way to do it is prospective studies with quality of life surveys, so like the SF36, for example, and health status surveys as well for the patient and also for the carers as well. That's I think, like the gold standard way of measuring it.
Thank you very much for your answers. I'm more than satisfied and give the floor.
Thank you.
The opposition will be continued by Dr. Moser, Associate Professor Applied Sciences at the Zuid University of Applied Sciences in Limburg. Dr. Moser was also a member of the assessment committee.
Thank you very much. Dear candidate, first, congratulations for completing this thesis. Also, I would like to congratulate your Dutch-UK supervisory team. Looking at your international orientation, I would have expected a 3rd country in your supervisory team. Your thesis provides us with a good description of palliative care and end-of-life care for people with vascular problems. You start your thesis with Cicely Saunders, the mother of palliative care. She was a doctor, a social worker, and a nurse. In your dissertation, you mention nurses several times. First, you say they document important information. You describe what they do. Then you say they could provide palliative care consultations and nurses could use the gold standard framework in community care. So you tell them what they should do. However, you rarely reflect on the bigger role of nurses in palliative care in general, especially when looking at all the morbidities patients have next to vascular problems, like cancer, like sepsis, and so on. I was thinking about advanced nursing roles that are essential to palliative and end-of-life care to people and life-threatening other diseases. In the Netherlands, and I talk from the Netherlands perspective, nurses are a full member of palliative care teams, and this is agreed on in national guidelines and standards. They have quite advanced roles, such as the palliative counselor or a palliative advisory nurse. They are educated in post-bachelor trainings, certified trainings, and they mostly work in hospitals and elderly care. Or you have nurse practitioners that are post-bachelor master programs, and these nurses can prescribe and describe medication and palliative treatment, but they mostly work in hospitals and hospices. And what are your ideas of advanced nursing roles, such as the palliative care case manager for patients with vascular problems? They could also be part of the early advanced care planning, and in collaboration with an interprofessional team from other units. So I'm curious about, as medical doctor or surgeon, about your ideas.
Thank you for your question, highly esteemed opponent. And thank you for your kind compliments as well. I agree. We have advanced care practitioners in the UK as well. So two of the names up there, Lee Ellen and Rebecca Anthony. They're not Rebecca Anthony. So Lee Ellen. There's another one up there as well. But yeah, so they have helped with a lot of this research, and they did some of the patient and public involvement work that we did previously, and helped with the data collection and writing the paper and input into how we wrote all four of these papers. And they are very good, and like here they can prescribe medications and do all of these things, but they were in the same situation as a lot of the doctors and surgeons, in that before we started looking at this work, they had that lack of, so these were vascular ones, and they had the lack of understanding of palliative ones. And I've started working with one from palliative care, and she has a lack of understanding of the vascular conditions, just like doctors do as well. But going forward, we're going to start we've already started an aortic clinic for patients who we're managing non-operatively, and they will be doing the consultation. There'll be one of the professionals who do the consultations for this. And at the moment, the other ACP who's involved in these papers actually does her own CLTI clinics. And so since doing this work, now we're a couple of years down the line, they've got very good awareness of, when we see them, we need to think about these things and have discussions about the care priorities and a preferred place of death. So actually we've gone back and looked at some of the similar data that we looked at for these previous studies, and now it's much better. So I think, yeah, they are excellent and really in a good position to do a lot of this work, and could definitely be the assigned person to be, the care coordinator for palliative care for a person. But they need to learn, like the rest of the vascular surgeons and the palliative professionals, in order to get that greater interaction between the specialities and understanding of the other ones.
And what about the advanced nursing role of a case manager? And not only helping and supporting and coordinating.
Yeah.
Do you think that that kind of advanced roles or the tasks that they substitute the medical task, they should remain with the medical professionals, or should there be a substitution to the nurses?
No, I think that roles like that would definitely be very good for advanced care practitioners. And one of the other things, one of the limitations though, is that we have doctors who are not vascular surgeons, so they're a bit like the orthogeriatricians, but for vascular. And actually, the people who end up deciding whether the patient goes to the theatre still does seem to be the surgeons. So it's looking at how do we change it so the decisions can be made more by advanced care practitioners and having more of their input to decide this person really shouldn't be going to theatre and he should just have their physical symptoms and psychological symptoms treated. So,
Thank you. Thank you very much.
Thank you.
The opposition will be continued by Dr. Buijsen, head of the Department of Anesthesiology at the Maastricht University Medical Center.
Thank you, Mr. Pro-Rector, and Mr. Candidate. Congratulations with your beautiful thesis, and congratulations also to your supervisor team and your family, of course. As an anaesthetist, I'm oftenly asked if the patient is fit enough to survive the operation. But hardly nobody is dying on the OR anymore, because your skills are much better than 20 years ago, and perhaps our skills also has been a little bit better. So that's not the question. The question is the ability for rehabilitation afterwards, I think. So ICU stay is important, and the condition of the patient. And when I look at table 1 and page 40 of your thesis, it's about the aneurysmatic group. In numbers, they are not so bad, with an ejection fraction of 52. Lungs are not good, but not very bad. So how can I discriminate the bad patient from the good patient? Let it call it that way.
Thank you, highly esteemed opponent. Thank you for your kind compliments and also your question. I think the numbers in that table probably might be slightly higher. They might look higher than they are, but I think that's because the number that actually had echoes to get the ejection fraction wasn't that high. So it's it's very common that we ask the anaesthetist and say, can you get the patient through an operation? And they always say, yeah, I can get him through an operation. That's not the question anymore, because mainly the anesthetic skills are so much better than they were previously. And but I think, though, there's not the research on this area, because, like we saw, there's a lack of research everywhere in terms of who should be making this decision. But personally, I think that sometimes when we've seen the patient in clinic and we've seen them on the ward, and we know we have a lot of experience in terms of how well these different patients do following the operation, and it's like you say, it's a lot about the social side of things and how much can they functionally recover. I think that and because they can get through the operation these days, I think that it's actually probably more appropriate for the vascular surgeon or the advanced care practitioner to decide on whether they should be for an operation. Because, like you say, it's not a question of can we keep them alive for the rest of the operation. It's should we be trying to keep them alive.
Well, in Holland, anesthesia is often combined with critical care, so I think we are still a very major player in this discussion. But why didn't you add a frailty score to your table?
Add what, sorry?
A clinical frailty score.
Oh, yeah. We did. We looked for clinical frailty, but it was never filled out. Okay. So that was one of the things that we did try to look for. But it was only filled out for, it was only in the electronic notes for a couple of the patients, so we decided not to include it. But if that should be filled out for everyone, and if they were seen more regularly by advanced care practitioners or nurses, then it's more likely that those would be filled out. And because of the relationship between anaesthetist and intensive care, often if the surgeon's not good at having the discussions, then it is actually very useful when the anaesthetist or intensive care doctor comes and has those pragmatic discussions about really what should be done. But I think that what I hope is that with work like this and more awareness, that we should be able to learn from the anaesthetists about how to have those discussions. And we're probably in a better, if we have the skills to do those discussions, we're probably in a better position to be having those discussions because we've met them quite a few times.
Okay, thank you very much for your answers, and we are always available for discuss a patient. So,
thank you.
Thank you. The opposition will be continued by Dr. Van de Water, vascular surgeon at the Maastricht University Medical Center.
Thank you. First of all, congratulations to you, your team, your family for this comprehensive work.
Thank you.
An underappreciated but very well-deserved topic that needs more attention. And not to waste more time for discussion, because I was really looking forward to the discussion with you. I would like to discuss with you something about timing. In chapter 5, you're investigating end-of-life care in CLTI patients in a cohort study. And you included patients that were admitted for revascularization or amputation. And you conclude there that palliative care is offered too little, too late. However, if you restrict your cohort to patients who are already decided to forego with surgery, whether it's revascularization or a minor or an amputation, I would say you're far down the line already in the decision-making process. And in the, I'm not very surprised then that it's offered too late, because we are already far down the line. Would there be a better study population to evaluate the question how much palliative care is applied?
Yeah, so that's one thing we did think about. Yeah, because we, like you say, we identified patients from the National Vascular Registry in terms of who was having an amputation or bypass for CLTI, and missed out all those patients who had already decided not for operation. So their survival cause of death would have been worse, and they should have been even more likely to. They should have been offered palliative care even more than the ones we looked at. But the reason we did it for these ones is because we thought there's often the conception of, oh, they're not end of life, I'm still operating on them, but according to the guidelines, they should be offered that palliative care, and it's that understanding of we can give them disease-modifying care, but also it's better to say, do you want some palliative care? Is there anything we can help in this area? Because if they say no, that's fine, and we give them disease-modifying care. But if that's documented, that means they've had end-of-life care, and so the decision was partly because of that. We wanted to kind of look at that group because they're also candidates for it.
Yeah. I totally agree that the patients that were not included here, it might have been more relevant, even more relevant to discuss palliative care. So what would you advise? What is the ideal timing then for CLTI patients to have palliative care discussed?
So the ideal time is once they have a diagnosis of CLTI, then that's the ideal time. If before that and they just have a diagnosis of peripheral artery disease, but you can have that structured care objective consultation with them in clinic or something along those lines to kind of identify whether there is anything else that they need help with. And if someone with PAD, they often have lung problems and heart problems and mobility problems from other reasons. If you kind of looked at them and thought, would I be surprised if they died within the next 12 months? And the answer is no, then it would be fine to offer them as well. But generally, I'd say a diagnosis of CLTI is a definite time. So if you see someone in clinic, diagnose that and plan to bring them in for revascularization, that's a good time to start, because often we try to revascularize within 2 weeks, but they send home and then they represent unwell.
No, I totally agree with you, because the general prognosis of a CLTI patient is bad, as we all know. So I think time of diagnosis is a perfect start for at least a conversation about it. And then you have another patient population in the vascular pathology, which is the AAA patient. And you focused on patients, I think, most that had a rupture, who were treated conservatively before, and then you analyzed or evaluated how many had palliative care consultation, which I think was merely terminal care, consult for palliative sedation or something like that, because they had a rupture already. So this seems like to be a missed opportunity, that it has only been offered when the patient was already dying. Would you agree that it would be wise to discuss in these patients palliative care earlier in the course? And would it be similar to CLTI at diagnosis, or is there another time you would prefer?
Yeah, I think, again, in clinic, once they've reached threshold size and you've made the decision not to operate on them, or possibly not to operate on them unless it ruptures, in which case you might consider an operation. At that time, I think letting them go home for a month and bringing them back in for a discussion to talk about things, and you can tell them that actually they're very unlikely to die of a rupture with platelets and antiplatelets and statins.
Henry Davies, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. Better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Henry Davies, the degree committee here present has assessed the quality of your thesis and your defense in view of its positive verdict and taken into account your previous qualifications. The degree committee has decided to grant you the degree of doctor. Professor Mees is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
Then, by the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Henry Davies, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Thank you.
Open it up, huh?
Very good. Very good. We'll make some pictures soon. Dear Dr. Davies, I'll keep it very short because the laudatio will be done by my co-supervisor, but I would like to congratulate you and we'll speak later.
I'll take my hat off.
You have to take your hat off.
Okay. So my role is to, first of all, congratulate Henry on his work to date and his successful defence, and I'm sure that his family are eternally grateful for that. Just some background on Henry. So Henry and I met back in 2022 when we had an opportunity through the NHR to fund an academic clinical fellow in palliative care and vascular surgery. And we had a number of applicants, and Henry was an interesting man because he was slightly older than most people, and he's had a fairly colourful academic career. So Henry did his aerospace engineering degree in Manchester, and then decided to go to Spain and then on to Taiwan to do English teaching and in his K-pop band. I think Henry got a bit bored, so he headed off to China again to play music, and he's on Spotify, but it's not very good. But anyway, so at that point he decides that he wanted to do something else, and he'd always had an inkling to do medicine, so he enrolled in Hangzhou, which is the university in south of Shanghai, to do medicine. And he did it in English to start off with. But that wasn't challenging enough for Henry, so he decided to do it in Mandarin, both written and spoken, and qualified, and then got his MD from the university. He then sort of headed back via circuitous route back to the UK and applied for our job. And he was... I think it's the first time when people have been slightly gobsmacked at the interview where somebody of his age would like to go ahead and do vascular surgery. And I think time has told us that he's done extremely well, and he's been very, very productive in a limited amount of time and has done some great work. And he's been very successful in getting the next step in the academic career in the UK, which is an academic clinical lecturer's post, where he now has 50% of time for research. So we're expecting bigger and better things and greater participation with the group here in Maastricht and possibly Amsterdam as well. So Henry, congratulations, well done. It was actually a superb performance.
Thank you. Thank you. I now give the word back to the proctor.
No, later on, during the reception. Dear Dr. Davies, also on behalf of the Board of Deans of the Maastricht University, it's a pleasure to congratulate you with your new degree you just acquired. I believe you clearly demonstrate that you have opened a lot of research in the field of end-of-life care and palliative care in patients with vascular diseases, and there already collaborations are also started up during this PhD defense. It's a quite unique situation. So I will close now this session, and we will take a picture with the new doctor on the stairs in the central hall. Hereby I close this ceremony.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually